And I think we should start. Good evening and welcome to ANWEP's monthly community conversation. This is the month of February, and as you all know, is Black History Month and also Heart Health Awareness Month. ANWEP created this space for communities of color, particularly Blacks, African Americans, and African immigrants, to have a safe space to discuss issues that confront us as a community, particularly our health. And this came about from the ANWEP's COVID-19 vaccines outreach and education project. One of the many tragedies of COVID-19 pandemic has been its disproportionate effect on minority and immigrant communities. So ANWEP has been working to ensure greater access and knowledge of COVID-19 vaccines through education and outreach to our population, with the goal of increasing the number of people that are fully vaccinated for COVID-19 in our African American and African immigrant communities in Texas. For this month, because February is Heart Health Awareness Month, our conversation is around what we can do as a community to cultivate and maintain a heart-healthy lifestyle. Before I bring in our presenter for today, Dr. Lynda Mbah, I would hand the mic over to the ANWEP Diversity Outreach Coordinator, Ms. Lynda Gray, to tell us about some housekeeping rules, webinar housekeeping rules for tonight's event. Ms. Lynda?
Thank you. Good evening again, everyone. Yes, just to take time out, because we have a very comprehensive, impacted presentation, I want to give a few housekeeping webinar rules of engagement for our conversation this evening. First of all, please mute your mics when you're not speaking. I want to encourage all of us to be able to type in our questions as we go through the presentation into the chat box. I will be monitoring those questions in the chat and will be able to, when Q&A time comes, I'll be able to definitely make sure that the questions will be answered in the order that they come, and then making sure that your questions are answered even if it's already answered during the presentation. So with that being said, I will turn over the mic back to Ogechi to introduce our guest speaker this evening.
Yes, thank you so much, Lynda. It's amazing that we have two Lyndas in the webinar today. So our Diversity Outreach Coordinator, Lynda Gray, and then the speaker and presenter for today is also Lynda, Dr. Lynda E. Mbah. And I'll read a little bit about her bio. It's packed, so I'm just going to summarize it so we don't take up too much time just reading her bio instead of listening to what she has to talk to us about today. So Dr. Lynda Mbah is an American Board of Family Medicine physician and obesity medicine specialist, specialized in both primary care and obesity medicine. She's been practicing medicine since 2010. She graduated cum laude from University of Texas, Dallas, Bachelor of Science in Biology in 2002. She had her two children and went on to obtain her medical degree in 2010 from the University of Texas, Houston Medical School, AKA, also known as McGovern Medical School. She completed her internship and residency training at Louisiana State University Family Medicine residency in Lake Charles, Louisiana. She is board certified in family medicine and obesity medicine. She sees patients across all age groups. She's fluent in English and Igbo. She's originally from Nigeria and now calls Frisco, Texas home. Dr. Lynda holds memberships in various professional organizations, including the American Academy of Family Physicians and the American Medical Association. She's also a member of the Medical Ethics Committee at Texas Health Presbyterian Hospital of Plano and the Advocacy Committee at Obesity Medicine Association, OMA. She received numerous awards in her college years, including Golden Key Honor Society, National Dean's List, and Phi Beta Kappa Scholarship Award, and recipient of Houston Medical Forum Scholarship Award. I'm almost like biting my tongue as I'm trying to pronounce all of this, but in a nutshell, Dr. Lynda Mbah is very, very well accomplished in medicine, and she loves to teach and enjoys medical students, teaching medical students as an adjunct faculty of the Department of Family Medicine, Tulane University School of Medicine, New Orleans, Louisiana. She lives in Frisco, Texas with her husband and their children. She's passionate about service and excellence. She loves to volunteer in the children's ministry at her local church. She enjoys reading and traveling, as well as spending time with her family and friends. Okay, I should have reversed and rehearsed and everything else before the webinar. Oh my goodness, you know, that's what happens when you have an intellectual powerhouse like Lynda in the house. You know, you're gonna stumble, you're gonna have things that will really twist and turn your tongue as you're trying to get everything right. But thank you so much, Lynda, for honoring our invitation. I welcome you to this webinar. And on a personal note, Lynda is a woman that I admire so much. She's a member of my organization, ANWEP. She's very dedicated to our organization. Lynda is the kind of person is when she feels something is worth her time, you know it. She really devotes her time. She's very passionate about things that she, you know, believe in, and things that and missions that resonate with her personal agenda. So thank you so much, Lynda, and welcome. You know, go ahead and feed us those golden nuggets. We're waiting.
All right. Thank you so much for that introduction. Thank you. And thank you everyone for joining. And I've had so many people registered for this that I'm encouraged that our community wants to, we want the knowledge. And I'm so happy. I feel honored that Ogechi invited me to do this talk. Like she said, we started during the week with COVID, and she had approached me for several talks, but I was busy. And I'm still busy, but I said, you know, well, this is heart health, and what work, my day-to-day activity has to do with the heart and the complications. So I just decided this is an opportunity to share what I know, and hopefully it will help someone. Without much ado, I hope you can see my screen.
Yes, we can see your screen.
Okay, so our topic today, like said earlier, was for a heart healthy lifestyle. This is a heart awareness. American Heart Association, February of every year is the Heart Awareness Month, and then it's also the Black History Month. So
Lynda, your microphone fades in and out. So we hear you and then it fades out. I don't know if everybody else can feel that, but yeah.
Can you hear me?
We can hear you, yes. But it looks like
it goes in and out.
then we lose the sound.
The sound. Okay. All right, let me see. Let me know if it continues. I'm gonna stay in one place then. This is Black History Month, and we're going to focus more on the things that affect us, the Black community. Not that we are not part of everything else, but the way it impacts us as Black. This is just one statistics for us to be aware. Black or Hispanics who experience cardiac arrest outside the hospital setting are substantially less likely to receive life-saving care from a bystander. So this is not something that is made up. It's on the American Heart Association website, and it's true. Even women, even worse for women. So if you are Black and you are a woman, it's even worse. Case of women is people don't want to touch them, you know. So when somebody has a cardiac arrest in a hospital setting, the bystanders are the greatest people that will be able to help them by CPR, you know. If you don't CPR, it is what saves lives. Just a few weeks ago, we had this NFL player, which brought everybody's attention to the issue of heart disease and what heart disease is about. You know, he has a very good build, but he still has arrest somehow, although we don't know much of the detail, but we know that administering CPR and him getting help helped him be alive today. So that's why it's very, very important for us to know as Black, and in this case, Hispanic as well, that when you have cardiac arrest outside the hospital setting, you are in a very, very, very dire situation. And it's very important for us to try as much as we can to prevent, modify our risk factors to help us now find ourselves in that kind of situation. And so heart health, cardiovascular disease risk factors. So the heart is also known as the cardiovascular system. And also vascular system is mainly the things, it deals with the circulation. It is the system, the things that are involved in circulating blood through all our organs. That's what the vascular system is. So the cardiovascular disease, it's the heart. The risk that play a major role in cardiovascular disease. Smoking. I know a lot of people join from different, when I share this different places, so there are so many people in different areas, and I'm sure there are other people from continents that are joining. So when I'm talking, I'm mainly talking for Americans as well, but also of these things will apply to us. I know smoking is not something that Nigerians do that much. So thankfully, we don't have that as part of our risk, but there are still people who smoke. So risk factor that you can change if you can work hard to modify that risk. Hypertension, that is the main focus of today's talk, because hypertension, if you can see later on, entails a whole lot. If you can control your blood pressure, modified a greater percentage of your risk factor for cardiovascular disease. And this is another way of saying high cholesterol. It's not just high bad cholesterol, there is also low good cholesterol. Good cholesterol is the one that hits your heart and minimizes your risk of heart disease. So we have different criteria for the gender. So women are supposed to have good cholesterol over 50, and men are supposed to have at least over 40. So the better your number, the more protective you are. And then the bad cholesterol in itself is the one that forms, that's the name sounds, it's LDL cholesterol. and it's the one that leads to plaque buildup, the things that will eventually block the artery.
Dr. Lynda, you still sound so far away. I don't know if it's the internet connectivity or you just have to bring the laptop or something closer to you. I don't know what it is, but it's kind of fades. It fades and then we hear you and we don't hear you. Much better.
Okay.
Yes.
It must be the connection where I am. So then I was high cholesterol and low good cholesterol. And also there's another part called triglyceride. So those are the main things that comprise your cholesterol numbers. The triglyceride, which is mostly driven saturated fat and carbs and starches and flours and simple sugars. And then the bad cholesterol, mainly also fatty food, saturated fat. And then the good cholesterol, there are several things that will help you improve those numbers. Exercise and eating healthy fats. Not all fats are bad. So as we may know that things like avocado and healthy nuts like almond nuts, those are good sources of good cholesterol. Many people are predisposed to having low good cholesterol. Others may have high good cholesterol. That good cholesterol, HDL, is the one that is protective. So you want to work hard to make your numbers better. Then the next risk factor is being overweight and having obesity. So obesity is very, very prevalent in American society. Other parts of the world are suffering from having less food. Here we have too much food, and that is leading not only just having too much food, the processed food, the inactivity puts us all at risk of having excess weight. And then the overweight, is having a body mass index that is 25 to 29. Body mass index is just a measurement, a ratio of your height to your weight. You want to maintain 19 to 25. Most Americans have obesity. Obesity is BMI of 30 and more. And then there are different classes of obesity. Class 1, which is the BMI of 30 to 35, and then 34.9. And then class 2 is BMI of 35 to 39.9. And then class 3, which we also call obesity, BMI of over 40. So the higher your class, the worse. So one of the things we are working as one of my specialties, obesity medicine. Many of us are suffering from this disease. It's a disease that hasn't been recognized by many insurance companies. So it's very hard to treat. When you have high blood pressure and high cholesterol and diabetes in this country, your medications will be covered. But obesity medication, drugs that we use to treat it, that are proven to work, are not covered by most insurance. So that's one of the things that we're working on, the advocacy committee in the Obesity Medicine Society. And this year, most insurance are coming around. So if you were trying to take anti-obesity medication in the past and it was try again, 2023 is different because most insurance are recognizing that treating obesity actually gets people off their diabetic medication and blood pressure. And that's what I see every day in my clinic. So some of them are coming to realize that, and most should work on our weight. It's easy for us to gain weight in this country. Talking from the experience of a Nigerian coming to America, we actually say when you drink water here, you actually gain weight from American water. It's just the way the society is set up. We don't exercise. You go to the grocery store, you pack the entrance of the store. I have several patients asking me to give them handicap pack, and I say, for what? I only give it to people who are elderly and they can't walk. Everything else, some people say they have anxiety looking for packets. Okay, I'll find it. You know, so people try ways to not be active. We have elevators to take us yes, and wherever we're going, our house, we park in the garage, you come inside, you sit down, you watch TV, you eat your food, you go to bed. So we have a lot of things that makes us inactive. So that increases that risk factor of having overweight and having obesity. The next one is type 2 diabetes. type 2 diabetes is very prevalent in African American community more than any other racial group. Well, not all of like the American Indians and the others, the Native Americans. And then the inactivity and sedentary lifestyle, I talked about it a little bit. That's another risk factor that we need to modify. And poor food. A lot of the food here is just processed food. And some of those food have, antibiotics and hormones put in those chicken. Like the chicken here is only 3 weeks old and it's already being eaten. And that's not seen anywhere in the world. So whatever makes that chicken blow up in 3 weeks also makes us blow up. That's what I believe is happening. So one of the things, those food choices, not many of us can have a garden and prepare organic food. Many people can do that. But when we do have the opportunity to buy food, we should stay away from food and processed food and frozen food to stay in the green veggie hours, buy the so you have less chances of overloading your food with lots of butter and cheese if you cook it yourself. All right. These are the risk factors. I'm going to delve into the main thing that is very, very, very prevalent in our society, and a lot of people have it. Some people don't know they have it.
Sorry to keep butting in, but I'm getting a lot of messages. People cannot hear. They said they are not hearing. I don't know what we can do to fix this. So
let me continue. Sorry about that. I don't know what's going on, but it's all right. High blood pressure. Can you see my screen now?
Yes.
So high blood pressure, we consider it a silent killer. The reason being that many people have high blood pressure, but they don't know. Many of the times, people do not have any symptoms when they have high blood pressure. When you actually have symptoms, your blood pressure is really extremely high. Because I have some patients, they don't monitor their blood pressure, and they say they know when it's high, but at that time it's already really high. Sometimes some people end up being lucky, or some God still wants them to be on this have high blood pressure for several days, and they will not pay attention to it until they start having nosebleeds. That's what will make them go 6. Somebody will tell them because it's too high. It's not. And some people, they will have excruciating headache. They might be thinking of other things besides that. So those are some of the common symptoms people may have. Some changes in, but a lot of us have high blood pressure, but we never know the symptom. We never have the symptom. So that's why it's called a silent killer. High blood pressure, or some of the times we call it hypertension. Some people call it BP. However you call it, whatever you call it, it still means your blood pressure is high. It has no obvious symptoms. So many of the times, that's why people really suffer the consequences, and it's really late. The best way is to protect yourself is to wait. The bottom number will be higher than that top number, because sometimes patients will call me and tell me their blood pressure is so and so, and they're giving me the top number to be lower than the bottom number. That's not accurate. So the number is always when your heart is actually pumping blood and it's beating. The bottom number is when it's supposed to be relaxed and it's filling up with blood. So that number is supposed to be lower. So the systolic number is always listed first, and the blood pressure is measured in millimeters of mercury. So we just use the abbreviation HG stands for, is the symbol for mercury. So the normal blood pressure should be below. So the criteria for the top number, you want it to range between 90 to 120. Sometimes patients will say, oh, my blood pressure is running low. I mean, it's low. And I say, what's the number? They say it's 100/70. Well, that's normal blood pressure. It's within that range. The top number should be between 90 and 120, and the bottom number should be between 60 and 80. Anything above that, you're now looking at high blood pressure. And there are several categories.
The normal number, the top number should be less than 120. The bottom number should be less than 80. And when you start deviating from this number, 120 to 129, it means you have elevated blood pressure. It's either or. So even if your top number is less than 120 and your bottom number is in the 90s, you still have elevated blood pressure, and it's not normal. At this number, I don't usually start medication. Making some lifestyle modifications, some changes will make this number go back to normal. One of the biggest changes that I notice a lot of people is sometimes you drink too much caffeine. A cup of coffee, which is 8 ounces of coffee, that little white cup is 8 ounces. It has 100 milligrams of caffeine. A lot of people live on coffee and drink and drink and drink and drink. So those caffeinated beverages will raise your blood pressure. Also, not just coffee. Some people don't drink coffee, but they are drinking energy drinks. And I look at this energy. Celsius is one of them. I've had patients that are drinking it. They don't drink coffee. They say they don't drink coffee. What else do you drink? And then when you go into it more and you find out they're drinking energy drink to stay awake, and it's 200 milligrams of caffeine. So that's 2 cups of coffee and serving of Celsius drink. And that patient thinks they're not drinking coffee, so they're fine. So those are some of the things that we can look into. So I usually, especially people who drink it to stay up, I tell them to cut down in half and then work your way down. Because that minimal change, when somebody is on the elevated range, it usually puts them back to normal blood pressure range. And then the other one is some people eat a lot of salt. None of us will take a spoon of salt and put in our mouth, but a lot of us eat a lot of salty food. Chips is the one that I find very common in a lot of people. They eat chips, and those chips are really high in salty. The salt content is very high. And so when people just make that minimal change, those 2 changes really transforms a lot of people's blood pressure to normal range. And if they continue, they'll stay in the normal range. But that's not for everyone, because there are some people who are now in the hypertension stage 1. That's when either the top number is 130 to 139 or the bottom number is 80 to 89. And then stage 2, and then we end up in the hypertensive crisis.
Wow.
This is the number when a lot of people say they don't have any symptom of high blood pressure, and they end up in the hospital with one other symptom. It's usually headache or dizziness, changes in their vision, or runny nose. Bleeding nose, nosebleed. Those are the 4 things that patients will go to the ER for, and they find out your blood pressure is high. And then they tell them, if you go to the ER with a blood pressure of 189 over 130, even though, and it's also in the crisis range, I give you any blood pressure medicine and send you home. They will tell you to follow up with your primary care. This only if you're an end organ damage. That is, you're having like your heart or your kidney or your brain is affected. So that means you're having chest pain, or they did your blood work and it showed you have an injury, or you're having stroke symptom. Then that becomes a problem. So they have to now treat your blood pressure in a very good way, because if you're having stroke, even though your blood pressure is high, we're not going to lower it immediately right away, because there is a goal you want to reach. At that time, if you lower it too much, the organ will not get oxygen and blood. So there are criteria to meet. So one thing every one of us should be doing is to have a blood pressure monitor and monitor our blood pressure at home. How do you check your blood pressure? This is where sometimes people will have blood pressure may be high at home, high at the clinic. When you try to check your blood pressure, don't check in a rush. You're trying to get out of the house. There's so many stress going on. You're watching something that is stressing you, or somebody talk to you in the man, and then you start checking your blood pressure. It's going to be high. unless you're just checking it to see how high did your blood pressure get, because that's not the accurate number. You need to avoid caffeine, cigarette, or other stimulants 30 minutes before you measure your blood pressure. Stimulants also include exercise. So if you just walked out and came back to the house and you start monitoring your blood pressure, your pulse and your blood pressure. So those are not good numbers. You have to wait 30 minutes. And then if you're on blood pressure medicine, you take it before you take your blood pressure. Also, you check your blood pressure before you take your medicine, because many of the times your blood pressure medicine is for 24 hours. That means if you take it at 8 a.m., it's in your system till 8 a.m. the next day. So it should control your blood pressure even at the 8 a.m. time when you're checking your blood pressure, or at 7 a.m. Because unless you waited till like maybe 2 p.m. to take your medicine, then at that time the duration of the one you took is already worn out or beginning to wear out. Empty your bladder beforehand, because that will blood pressure reading the top number about maybe 5 to 10 points. Also, find a quiet place where you can sit comfortably without any distraction. And when you do sit, you should keep your legs on the floor, and then keep your hand relaxed. You're not gonna be. If you're wearing any outfit, you gotta remove the arm part of it so that your skin will be touching the blood pressure monitor. And especially if you're wearing something thick. And also, don't try to pull up the sleeves, because sometimes you pull it up and it goes up to your upper arm, and then it becomes tight and it forms a tourniquet. And that's gonna cause your blood pressure to be full. And it's also important to right cuff size. So if you have a big arm, most of the time the regular blood pressure cuff will not fit your arm properly. You're checking your blood pressure, it's going to be running high. And so that's not giving you a good, accurate reading. And then also, if it's too loose, it's also going to cause your blood pressure to be falsely low. And so you will think your blood pressure is running very good, it's good, and not knowing that you're using the wrong cuff. So what I normally do, if we have a discrepancy in our blood pressure reading, I have patients bring their machine to the office, and then we will check ours, check theirs, and see where the is. Now, sometimes patients will get anxious when they come to the clinic and their blood pressure will run higher than their normal. And that's also when it's good to cross-check. And that's also what we can do a remote. All right, so you should record your number. You can write it on your phone, not on a piece of paper, because sometimes people write it on a piece of paper. They come to the clinic and say, oh my God, I left it on the table. And so it's good to, if you must write it, take a picture of it. That way you have it on your phone. All right, so we're gonna move on to, this is the hypertensive crisis. It requires medical attention. If your blood pressure reading suddenly exceeds this number, you wait 5 minutes and then retest it. If your readings are still unusually high, you gotta contact your doctor. If your blood pressure is higher than this number, 180/120, and you are experiencing these signs, organ damage, chest pain, shortness of breath, back pain, numbness, weakness, changes in your vision, difficulty speaking. The first part are signs of heart attack, is chest pain and shortness of breath and back pain. The numbness, weakness, and changes in your vision and difficulty speaking, those are signs of stroke. And so when you have high blood pressure, those are the two organs, actually it's three. Those are there are three main organs that are affected when your blood pressure is uncontrolled. The heart, and that's when you have heart attack. The brain, that's when you have brain attack, which we call. And then the kidney, that's when you have kidney. Patients on dialysis, they don't even have diabetes. It's from uncontrolled blood pressure. And that's why we also call it a silent killer, because somebody will not know. That kidney requires a lot of oxygen. It's a very small organ. When your blood pressure is high, it causes for the pressure to be too high that the organs are not getting oxygen supply you're not getting oxygen supply to the vital organs. So those three main organs are the ones that suffer a lot. So when you have these changes and your blood pressure is high, call 911. if you are in the US. Don't drive yourself, please. Call 911. They will get to you faster, and they'll get to the emergency room faster than you would. You can't try to save money. You have to save your life. I had a patient die in 2020 February. He was having pain, and his insurance is hiding out. He didn't want to go to the emergency room. He was 60-something years old. He didn't want to go to the emergency room because he has high deductible plan. His chest pain started at 2 p.m. He called my office at 8 a.m. to schedule an appointment to see him. He came, saw him. Of course, I wasn't the one that scheduled it, but he wasn't supposed to have been scheduled. He would have been directed to go. But he told them he didn't think it was his heart. Anyway, he was having a heart attack. It started the day before, but he eventually died. And what for? You know, your money that you're making, who is going to do it? So you have to know when it's time to seek care. Try to cut corners. The blood pressure, this is, we already talked about what the numbers are. 120/80. That's the number you need to remember. You want to be lower than that. These are some of the things, how the blood pressure can affect the organs. It can lead to stroke. We're going to go through these numbers. How can high blood pressure lead to heart attack? A heart attack occurs when the blood flow that brings oxygen to the heart muscle is severely reduced. This happens because the coronary arteries means the heart arteries that supply the heart with can slowly become thicker and harder from a buildup of fat, cholesterol, and other substances, and we call it plaque. You know, like the dentist, they remove plaque from your teeth. In the arteries, which is the things that blood flow through to all our organs. Plaque can build up from fat and cholesterol, and that's also why, you know, healthy eating is very important, because when we're eating some kind of food, those food cause plaque formation, and eventually those arteries will start narrowing, and eventually it closes up. This plaque can break open, and a blood clot forms, and it blocks the flow and that's when heart attack. Basically, this is the heart, and it has all these arteries. Aorta is the big artery that comes out of the heart, and it goes down through the middle of our body. This red thing, it goes down all the way, and it comes to our hip. It breaks into the femoral arteries. It goes down to our legs, and they become even smaller and smaller and smaller. That is the vascular system, the circulatory system. The blood will flow in and out of the heart. This one is where the oxygenated blood, which is the blood that has oxygen, that's why it's red. It goes out to your body. And then the blue one those are the veins. And then they return the blood. When the blood circulates, they lose the oxygen that they carried back with less oxygen, and they go back to the heart to get more oxygen. And then that's what's happening, circulatory system, it circulates. These are all the arteries that can get blocked during a heart attack. Any one of these, if we have blockages, that area of the heart that it supplies, let's say this one had a blockage, then this whole area of the heart will be, they will lack oxygen and it will be dead. And that's the heart attack, when that person will be having a heart attack. And these blockages can be seen on EKG. So when you go and they do an EKG in emergency room, they're checking to see, is there any abnormal reading that they can see, showing them anything that is showing that there's lack of oxygen getting to some areas of the heart. It will show on the EKG. Sometimes it will be very minimal, sometimes it will be obvious, and then we know that person, they call that the person is having acute MI, because it has a different way that up on the. This is the process. Fatty deposit called plaque will build up on the walls of the artery. You can see this is where the blood flows, supposed to flow, and these are the walls. And then in between these walls, the intimal layers, that's where those plaque will be building up. And it pushes, you can see this yellow thing, that's the plaque. And it's made up of cholesterol and other debris. And it starts pushing out this. Eventually, this will be narrow. There won't be enough for oxygen or blood, because oxygen is carried in the blood. These blood have oxygen. Oxygen is what the tissue needs to survive. Just like we breathe oxygen, these arteries and our tissue, they carry the oxygen that is supplying the tissue in our body. So in this case, it's heart muscle. So when this plaque becomes unstable, you see it broke out this little wall and it came in here. And that's also when it's called the blood clot, and it's called thrombosis. And it starts inside this artery and the wall breaks up and this causes this blood clot. So sometimes people say they had a stroke. That's also the blood clot that can block the artery in the brain. So this one, we're looking at the heart artery. This also, we have the same similar artery, but it has different names in the brain. This whole process also happens in the brain and the person will have a stroke. All right, so the next slide we're looking at, when this, as the thrombosis continues, you can see this is looking bad, and this artery here, we call it the lumen, that's the opening. It's getting smaller and smaller. And this is causing blood supply to that heart muscle to be reduced, and eventually that muscle tissue will die. Heart is a muscle, so it's muscle. Nothing else, it's muscle itself. So if that clot completely blocks that artery, then all that muscle below that blockage will be dead. You see the color here. These are dead cardiac muscle tissue. So, and that's what we call MI, myocardial infarction. Okay. So what are the warning signs of a heart attack? Many people will, classic is uncomfortable pressure, squeezing, fullness, pain in the center of the chest, and it lasts more than a few seconds, or it can go away and then it come back. This is classic for men. Women, we do not have that pressure feeling in the chest most of the time. Also, people with diabetes will not have typical chest pain or squeezing in their heart or whatever. Many of the times, women will have GI symptoms. They will think that they have upset stomach, they are bloating, they have gas and all that. And that's why when a woman comes in with those kind of symptoms, you have to do an EKG. You have to rule out, depending on their age and their risk factors. Of course, not a 13-year-old, you start doing all that, unless they really have a very high risk heart disease. But otherwise, any woman of age that is experiencing GI symptoms, you also have to rule out that they're having a heart attack. So some of the other pain or discomfort in both arms. Sometimes people can have it on their back. They can also have it on the neck or jaw. The stomach, I mentioned that. Shortness of breath, with or without chest comfort. Other signs such as, so when you're experiencing shortness of breath, most of the time, the shortness of breath is because you're not getting oxygen to some areas, and that's what's causing that discomfort. Sometimes people may not have chest pain, but they're just having shortness of breath. Other signs other signs of the heart attack as breaking out in a cold sweat or nausea or lightheadedness. These symptoms, many people will confuse it for something other than heart attack. So it's good to watch out for that, us in the healthcare community and you as a patient. So just a little break. How did we go from this heart, this is how the heart looks. This is a 3D image to this is now the symbol we use for the heart. I don't know how that happened, but how high blood pressure can lead to stroke. High blood pressure is the major risk factor for stroke, and stroke is the 5th leading cause of death in America. High blood pressure can cause those blood vessels supplying blood and oxygen to become blocked or they burst. So when they are blocked, they are called ischemic stroke. When they burst, they are called hemorrhagic stroke. We'll get to that next. High blood pressure will damage arteries throughout the body, creating conditions in which they can burst or clog more easily. Weakened or blocked arteries in the brain put you at a much higher risk for stroke. Hence, this is very important for us to control our blood pressure. There are 2 kinds of stroke, ischemic and hemorrhagic. Ischemic is the most common stroke. That is the blockage stroke. That is where the artery is blocked. either by the plaque or the blood clot. So a stroke, sometimes some people may call it brain attack. That just explains it easier, it makes it much clearer to understand what a stroke is. This ischemic stroke occurs when a blood clot blocks the blood flow in the artery within the brain. And so when this happens, like here, so the blood clot blocks this artery, and it's this area supplying this brain area, and then this brain tissue are dead. The other one is hemorrhagic stroke. It occurs when the blood vessel bursts within the brain. And it can burst because of extremely high blood pressure. And there is no way where for the pressure to go. Just like a frozen pipe, you know, when the pressure is so high, there's nowhere for that pressure to go. It will just burst open. And blood, and that's what we call hemorrhagic stroke. And it usually happens on the outside of the brain. Okay, so the next is 87% of strokes are caused by this ischemic stroke, the narrowing or clogged blood vessels in the brain. And high blood pressure causes that damage to the lining of those blood vessels, and it causes the narrowing of the artery, and then causing limited blood flow to those vital organs, and that leads to stroke, heart attack, and kidney failure. Ischemic stroke occurs just especially what I just explained. And also we call it arteriosclerosis when this plaque forms. So sometimes we can use the word arteriosclerosis. You may go and have a chest X-ray done for shortness of breath or pneumonia, and the radiologist will say arteriosclerosis of the aorta. When they point that out, that actually means you have increased risk of heart disease and stroke, because you already have that plaque. It's already building up to where it's actually showing up on the plain chest X-ray, and you need to modify your risk by those things, those 7 risk factors that I mentioned earlier. So whenever you see this word arteriosclerosis, it really means you are really at a very high risk. This one. So this artery here, the aorta, the big artery that I showed, this is not showing the bottom of it. This comes here, and then it goes all the way to the brain. That same big artery, this aorta, that one that is coming out from the heart, it branches up also in the shoulder area. And then from there, it goes up to the brain. And it's named this right common carotid artery, and then there is this other one, the jugular, and the right internal carotid artery. So they all travel to the brain, and they spread and make branches. The farther they go, the smaller they are, and the easier for them to even be blocked. So this arteriosclerotic plaque reduces this blood flow in this internal carotid artery, this artery right here. That's where it's showing how it's narrowing it. Okay. So hemorrhagic stroke also makes up 13%. The other one is 87%. That's the most common cause of stroke, the most common type. This one occurs when a blood vessel ruptures, and then it also happens due to chronic blood pressure and aging blood vessels. Those are the main common causes. And this high blood pressure puts the strains on those vessels. So those vessels becomes weak, and it's easier for them to rupture. Just like anything, wear and tear makes it easy to tear, aging. And then the next one is, how do you recognize stroke? They have this FAST acronym. It's called FAST. Basically, face drooping. So you can ask the person to smile, and you'll find out that their smile is uneven. One side is lower, and the other side is not moving. And then they can have arm weakness, arm drifting towards downwards. So usually the way stroke happens, when it happens on the left side of the brain, it affects the right side of the body. So usually when somebody have left arm weakness, that stroke is on the right side of their brain, because it causes, that artery causes on the neck area. It will, when it's coming down from the brain, it causes to the opposite side. So that's why the symptoms are opposite on the body. Then speech difficulty. Some people may have slurred speech, or they are incoherent. You're talking to someone, they are not making sense, and they're gibberish, or they are writing and they're not making sense. that is a common sign of stroke, and the person doesn't even know it. So you should be the one that will initiate emergent care on their behalf, because they don't even know that they're not even talking right. And they will find trouble, they will have word finding. So it all depends on the area of the brain that is affected. Each area of the brain has what specific thing that it handles. So the speech area is different. And then the one that makes us articulate word is different. So sometimes the person might be speaking and speaking, but they are just not making sense. Some people may not talk and they're trying to speak and they can't speak. Some people might find it difficult to name an object. So it all depends on that area of the brain. But if you sense that somebody is having a stroke symptom, please, that's the time to call 911. Other symptoms of stroke are sudden onset of numbness, weakness of the face or arm or leg, or especially on one side of the body, because stroke doesn't usually happen on both sides of the brain. Like I mentioned earlier, one side of the brain controls the opposite side of the body. So most of the time, stroke will not happen on the whole brain, the two sides. So usually when somebody has a weakness or numbness on one side, you have to be on alert for stroke. You have to start working, either calling for emergency or taking care of that person to make sure that it's not stroke. Confusion, trouble speaking and understanding speech, trouble seeing in one or both eyes, trouble walking, dizziness, loss of balance and coordination, because those areas are controlled by a certain part of the brain. Basically, on the bottom, the base of the skull controls the coordination and balance. Severe headache with no known cause. Now, that hemorrhagic stroke, one of the biggest symptoms of it is headache, because the blood is irritating to the brain. So that hemorrhage, when somebody has a bleeding stroke, they usually have headache, because blood touching those brain cells, it irritates it, and their symptom is usually headache. So that's why when somebody is having headache, the worst headache of their life, when they're complaining of headache, not just any headache, you're stressed and all that, but just a headache that is quite unusual. Somebody that never had a headache, and they know that you need to watch out for stroke symptom. All right. How does, of course, you gotta check their blood pressure also. How does stroke impact Black Americans? Black Americans have a higher prevalence of stroke and the highest death rate from stroke. So some of the racial group can have stroke and they survive, but most of the time, African Americans will die just because they have stroke, and it's not acceptable. So we have to do more to help ourselves. Those who have diabetes and have an ischemic stroke, which is caused by the clot formation, they are more likely to be Black. Also, Black stroke survivors are more likely to be disabled and have difficulties doing daily activities. So that's just part of the statistics that we need to work on trying to change for ourselves. Why are Black individuals at higher risk for stroke? Well, it's not very clear, but over 2/3 of Black Americans have at least one of those risk factors that I mentioned earlier. The risk factors for cardiovascular disease are the same risk factors for stroke. The risk factors, maybe some people may not have heard me, that is the cardiovascular risk factors: smoking, hypertension, dyslipidemia, overweight, obesity, type 2 diabetes, inactivity, sedentary lifestyle, and poor food choices. Those are the 7 risk factors. And a lot more African Americans have one or more of those risk factors. And that's probably one of the reasons, but it's not all of it. High blood pressure is a really big risk that I focus on today because of how prevalent it is and how common it is and how easy for most of us to be able to change that. Over 50% of Black Americans have high blood pressure. It develops earlier and more severely in Black Americans. It's not even just Black Americans. There are some people, I've done medical missions in Nigeria, in my village and all that. A lot of people, we check their blood pressure. People are walking around with 200 over 150 blood pressure, and they're walking around, and that's stroke. And the next minute, the person has a stroke. The thing is that they don't correlate it as a blood pressure issue. They find their neighbor or their co-wife that they think poisoned them or did something to them, So ignorance is, we need to be knowledgeable of risk factors and how we can change those things and not call everything the attack, that somebody has attacked them. Yes, your blood pressure or your brain got an attack, but it's not because a human being attacked you. It's because you did not control the blood pressure and modify your risk. So it develops earlier and more severely in Black Americans. Historically, there are certain factors like the historical factors and systemic factors, adverse social determinants of health, which is, where you were born and where you live. Certain things can influence make the risk higher. The determinants include lack of access to care, lack of access to healthy food, because there are some places we call food island. They are starving. They don't have grocery stores. All they have is convenience stores. Convenience store don't sell healthy food. It's usually packaged food that will actually make the blood pressure higher. So those are some of the things that are working against us. And other societal issues, also including lack of adherence. A lot of patients will take their medicine 1 or 2 times and their blood pressure is normal and they stop. But the medicine is to control your blood pressure. You're not supposed to stop. You're supposed to continue to take the medicine. Otherwise, your blood pressure will still continue to go up. So some things will cause the blood pressure to stay uncontrolled. Certain medications also may be less effective in controlling the blood pressure in Black people. And also sometimes we require 2 or more medications to have it controlled. When you start telling patients that you will need to add another medication to control it, many of the times people don't want to take another medication. But, there's no point trying to take medicine that you will not take to have your blood pressure controlled. So it's good to have it controlled so that your risk will be lowered. And diabetes is the other thing. Things being sometimes the diet, sometimes it's our genetic makeup. It makes it easy for us to gain weight and retain weight. And sometimes most of us overeat, and we also overeat the wrong food. We eat more starchy food. For Nigerians, we eat more. I'm one of them. Rice. Everybody you go is rice, and then we eat lots of fufu. Sometimes people are trying to eat a different kind of fufu, and they want to do this cocoyam flour, call it, what is it called? Oatmeal flour. All those things are starch. If you want to modify your starchy intake in terms of fufu intake, please use veggies, something like broccoli. You can do cauliflower. Now there is another one. It was one of my patients told me about it. It was green plantain. So that actually lowers your sugar. If you can blend the green plantain and then put it in a pot and stir it, it turns into something palatable that you can enjoy your soup with. So those are some of the changes you can make, but don't go and exchange one fat, dairy, for another fat, semolina. No, another starch. Those are starch. Starch is the culprit. They turn into sugar. A lot of patients will say, but I don't eat sugar. Yes, you don't have to necessarily eat candy and cake and ice cream, no, or drink soda. You can be eating lots of rice and potatoes and pasta. Americans are pasta and some are potatoes, and Hispanics are tortillas, and then many people are chips. So those are some of the things that make us have diabetes, because those starch will turn into sugar, and that's diabetes. And most of the times people don't know they have diabetes unless they are. That's the only way you'll find out. Or they end up with issues that send them into the hospital and they check their sugar and they find out they have very high sugar. So weight and obesity is the other risk that is very common in African American, which is almost 70% of Black men and 80% of Black women are overweight. Changing those things will change our life for better. Nearly 30% of Black Americans have high levels of the bad cholesterol, which is the LDL. So those are all these risk factors that can cause that. Sickle cell anemia is in Black. So it's a genetic disorder. There's not much that one can do about it. It gives us a higher risk of stroke because of the sickled cell those are blood that are not round like the regular red blood cells. They are sickled. It looks like they're going to be poking holes. So they don't pass through those arteries easily. So it puts them at risk of having stroke. In Nigeria, many people with sickle cell disease end up dying younger. Here, they are in America, they have treatments and they live and they even have children. So I do have them in my clinic, which is, you can see the power of medical intervention. You know, those people live and have children, but they do suffer from chest pain, and they have increased risk of stroke also. Smoking, 15% of Black adults smoke, doubling their risk for stroke. So eating too much salt. African Americans may have a gene that greatly increases sensitivity to salt and its effect. So it might not be you're eating too much salt, but you might be too sensitive to salt intake. Like for me, if I eat anything salty, my legs will be swollen the next day. So I'm very sensitive, so I know that. So if I taste anything that has salt too much, I won't even eat it. For any regular person, they will not taste the salt. African American adults face daily stressors that may increase the risk for stroke. Stress is a very big risk. A lot of us are going through one stress or the other. When you're stressed, your blood pressure is high. And that really, really increases your risk for stroke. So there's no need, don't stress, just hand it over. There are certain things we can change, some things you cannot change. If you're somebody of faith, you can pray about it, but if you can't change it, just try to relax, take a deep breath, sleep. We'll get to that later. How blood pressure can lead to heart failure. This is another risk that many people don't even think about. When I tell patients, because they'll tell me their grandmother had heart failure, congenital failure, they don't even know how it happened. I tell them it's control blood pressure. And when I do, like when somebody is 40 or older, or actually when you have high blood pressure or anything with the heart, your heart fast. If you come to my clinic and it's your wellness, you have that history, your annual physical exam, I do EKG just to check your heart. Now, many people, the EKG changes that you can see earlier on will be what we call left ventricular hypertrophy. So that is when the heart muscle is hypertrophy. That means it thickens. The heart, like I said earlier, is a muscle. Just like the bodybuilders will work on their arms and they get these biceps and all that, the six-pack. The heart muscle, when your blood pressure is high, is working really hard, and then it stiffens that heart. That heart becomes initially hard and tough. And it will still be the same size, but it's hard. The inside muscle is thickened. They have more muscle. It's just like a muscle builder. This muscle will just be thick. If you cut it open, it's just thick, and the inside is small. But the outside of your heart looks good. It looks fine. Then what happens over time when your blood pressure continues? So when you do EKG, we see that left ventricular hypertrophy. It just shows up on your EKG, and I tell the patient, this is from long-standing uncontrolled high blood pressure. So you need to modify your risk. So when that happens, this becomes eventually that heart, it will go from being stiff, it just becomes weak. When it becomes weak, it will be fluffy like a balloon, and it will become big. And when you do a chest X-ray, they will say cardiomegaly, meaning your heart is a little bit enlarged, and it can be seen. And that's an early sign that we can see of heart failure before the person even starts having symptoms. And then, so when that thing happens, your heart is pumping, but it's not pumping enough to push out that blood from the ventricles. I had a video, but it wasn't shown. So what was happening here? This is the heart muscle of the left ventricle. Do you see the muscle in between? This is the left ventricle, this is the right ventricle, this is the upper chamber, the left atrium and the right atrium. So the left ventricle is where the oxygenated blood is, and then it flows out, and then it comes in from the right, and it goes in and it's oxygenated. Well, when your blood pressure, when your heart is pumping, that's what we feel when we feel your pulse. That's your heart beating. So that's blood. So that's why when somebody dies or have a cardiac arrest, there's no pumping going on. So you will have to pump them yourself, apply pressure to have that kickstart it. So this muscle now becomes weak. and it cannot pump enough blood. It's pumping, but it's not pushing out enough blood, and that's heart failure. So those blood are not coming out to your heart to supply those organs. So it can also lead to damage to the arteries around the kidneys and interfere with your ability to filter blood effectively. The kidneys are the place that filters and removes toxins from our blood. So that's why when the kidney fails, that person ends up being on dialysis eventually, so that the machine will help them remove the toxins from their body. Because that's what kidney does without us even knowing. The kidney is removing it and we're peeing it out. But if it fails, it can't do anything. Machine has to do it for you. It can also lead to vision loss. Oh, so one of the symptoms of heart failure, let me just talk about it now, is some people will have difficulty sleeping. Normally, maybe you sleep with one pillow, and now sleeping with one pillow, you're not able to. If you lay down flat, you feel like your heart, you're having shortness of breath, like the fluid is coming up to your heart. Those are some of the signs of heart failure. Also, the other thing is some people will have swelling in their legs. Not the swelling that we get, some of us who are on our feet all day, at the end of the day, the legs are swollen. No, this swelling is swollen. You are swollen. You touch it, you also feel it going in, and you're having shortness of breath, and you have to sleep with that many pillows. And you have to, some people, they will not be on an incline. They won't lie on their bed. They will be sitting in their living room or wherever they have a chair that they can recline up. Those are symptoms of heart failure. So if you have any relative that is doing all that, please, you need to have them taken care of, checked out, so that they will get intervention sooner than later. So blood pressure can lead to vision loss also. The strain, the blood pressure can cause strain or damage to those blood vessels in the eye. And that's also one of the symptoms of high blood pressure, because somebody may be having visual loss, because that pressure is too high. And it's affecting the artery, the tiny little arteries that go into your eyes. How high blood pressure can lead to sexual dysfunction. It can lead to dysfunction in men, erectile dysfunction, and it may contribute to lower libido in women because of that high blood pressure. Just like I mentioned, that big artery goes down, goes to the leg, and it supplies all the other organs, everything, your leg and your reproductive system. Those arteries going to the male's reproductive organ. If they're not getting oxygenated, then that is when that man will be experiencing erectile dysfunction. And that's why it's very important to control your blood pressure. When you think you're having erectile dysfunction, you need to check your blood pressure and make sure it's under control. Because once the flow of your blood is flowing normally, then every organ will be getting enough oxygen. The blood carries the oxygen. So let's remember that. And oxygen is what keeps those organs alive. All right. And then the next one, well, this is just for us to take a break. What are the modifiable risks to improve high blood pressure? Those that can be improved or treated are cigarette smoking and exposure to secondhand smoke. So you may not smoke, but if you live in a house of somebody who smokes, even if they don't smoke in the house, you're getting that smoke. You're getting that nicotine. So you need to quit. You need to stop hanging out with them. And they smell. I've had some patients quit just because I'm very sensitive to the smoke. So they may smoke in their house, smoke outside, and they come to my clinic, especially if they've been in the room for a while, and I open the door. I can smell it. And they say, but I didn't smoke. Yeah, but I can smell it. Your hair, it's on your hair, it's on your clothes, and they don't smell it, but there's somebody else who doesn't smoke can smell it. And that's secondhand smoke. If you hang around that person for a while, you start experiencing the smoking, the problem that smoke causes. Diabetes, being overweight, and so those are all the other risks that I mentioned earlier. Those are the same risks that you get for cardiovascular health. That's the risk to modify for blood pressure health. And in this case, it added high sodium, low in potassium, and drinking too much alcohol. Now, some people may say, oh, but alcohol is good for your heart. There is moderation. And there is a particular alcohol. You can't just drink a hot drink and say it's good for your heart. It's not. It's mainly red wine because of the flavonoids, the things in it. It's not drinking those hot drinks, though they're not helping your heart. Factors that can be changed or are difficult to control. That's your family history. So if you have high family history of high blood pressure, you are an increased risk. I mean, you can't do anything. Race, being African American also puts you at a higher risk of having high blood pressure. In age, as you age, it makes you prone to having high blood pressure. So some people may have normal blood pressure. As they age, they start going high. Now, that 120/80 that I said is the normal blood pressure. It is not the criteria for older people. Older people need a higher blood pressure. We actually wanted 140/90 or less. So they need a higher blood pressure to perfuse their organs. So we're not trying to bring a 70-year-old's blood pressure to 120/80. So you need to check with your doctor. Also, your other risk factors, like if you've had stroke or you had heart attack, then you need to check with your cardiologist or neurologist for where they want your blood pressure to stay. But normally, older people, we don't want them to have lower blood pressure because it puts them at risk of having dizziness, lightheadedness, and then fall. When they fall, most of them go downhill from there. So we try to prevent fall. Gender, being male is an increased risk for high blood pressure. And then chronic kidney disease, when you have chronic kidney disease also, those are some of the things you can't change because the kidney is an organ that is involved in controlling the blood pressure. That's why some of the blood pressure medications target the kidney. Most of them are targeting the kidney. So if your kidney is already diseased, then it's not working up to par what it's supposed to be doing. Obstructive sleep apnea. Now, it's put in here as some of the things that can be changed, but also it says difficult to control. Obstructive sleep apnea is one of the things that are undiagnosed in many people. A lot of people having excess weight puts you at risk of that. We see it mainly when people snore. You know, a lot of times we deny snoring. We don't want to accept that we were snoring. Yeah, you can snore when you have cold and stuffy nose. But if you normally snore, it's good to check out to make sure you don't have sleep apnea. Sleep apnea is when your brain is not getting oxygen. And then you have an apneic episode, meaning you lack oxygen supply to your brain, and then you stop breathing. So many people might be, because it's the spouse that will say, I want my husband to be checked for sleep apnea. And you have to do a sleep study to make sure that's what you have. But there are certain things that will point us that that's probably what you have. When you have untreated sleep apnea, it puts you at risk of having high blood pressure, high cholesterol, excess weight, diabetes. So not getting good amount of sleep is actually not a good thing. So, and if you have this sleep apnea, people can die in their sleep because they're not getting oxygen. And also that's why sometimes when people say, give me sleep medicine, I have to rule out they don't have sleep apnea. Because what happens is if you give them sleep medicine, the process that the body uses to wake them up, you are trying to overcome that and give them sleep medicine so they can just sleep through it. So the brain wakes up because it's not getting oxygen. And that's when that patient will say, and the family member who is watching them will say, wow, what happened? That's their sleep apnea. And they need to go and get sleep study, and they need to see a sleep specialist and start being on either sleep machine. Now they have something that's called Inspire, so you don't have to wear a mask. It's very new. So many people like it. I don't know what the coverage is, in terms of insurance, but we need to get this treated, obstructive sleep apnea. Factors that can be changed or are difficult to control, it continues. Socioeconomic status, that you may not be able to change unless something happened. Maybe you go to school, you have a good profession. Psychosocial stress, you may have all the money you have in the world, but some people may have some mental health issues and things that are bothering them, and it puts you at risk of high blood pressure. This can affect access to basic living necessities, medication, healthcare providers, and ability to make a healthy lifestyle. Now, in the Dallas Metroplex area, we have healthcare providers everywhere. But the problem is some people may not find a healthcare provider that they want. People drive 2 hours to come and see me because they have seen other people and they don't feel like they're being taken care of. So it's really, really good for you to find somebody that you feel comfortable with. And I tell patients, you have to get family members, find a doctor that you can tell have a blood in your buttocks. If you cannot tell your doctor that, you got to find another doctor, because that means you will be hiding things. And that's also one of the reasons I don't even like to take care of my staff. And sometimes they say, oh, what's wrong? No, you won't be able to tell me all the pictures. Would you tell me that you drank alcohol and that really that your symptom is from whatever party you did last night or something else, or you have an STI. No. So find somebody who you can share your most intimate personal matter with. Don't just get somebody just because other people are seeing that person. Because if you're hiding things from your healthcare provider, it's for your own detriment because they don't have the whole picture. Because all the pictures plays into it gives us a better picture if you tell us everything and you can put it together and say, oh, okay, is this? Or well, we need to look into this further. And then the next one is so what are the factors? So taking care, ability to make a healthy lifestyle changes. And those include, how can I control my blood pressure? Don't smoke, avoid secondhand smoke, reach and maintain a healthy weight, eat a healthy diet, low in sodium, unsaturated and trans fat. These are things like shortening, microwave popcorn, frozen pizza, refrigerated doughs, and all that. Fried food, French fry, donuts, fried chicken, fish. We eat a lot of fried fish, that tilapia fish, the Nigerians. We need to cut down on that. Maybe some of us eat it every now and then, but you gotta bake your fish or broil it. Don't stay, maybe every now and then you can eat the fried tilapia, but it's not healthy. It's just similar to the fried chicken. And now non-dairy coffee creamer. Some people will pour coffee creamer in their coffee and they say, I'm only drinking coffee. I don't know why I'm getting weight. Well, you're using a lot of creamer. Have you seen how many calories and sugar in that creamer? So what I do myself, I substitute my coffee creamer. I use a protein shake as my coffee creamer. And then I can put a little bit of coffee creamer in my coffee. But use protein shake instead because you're getting protein. And that's usually my breakfast because you get that protein and it's a meal. Not pouring all that coffee creamer. I have somebody who comes to my office, she'll take all that coffee creamers to make her coffee. That's not good. It's not healthy. And you can't claim you have not eaten. You just ate, you drink coffee a day. No, that's a lot of bad food. Margarine and butter and lard. So you may not be eating margarine plain on your bread, but if you're eating those foods that are made with those thick margarine, us, African community, it's mainly, what is it called? Meat pie and chin chin. It's okay to eat it every once in a while, but if you're buying it and keeping it in your house and eating it every day, you need to stop that because you're actually increasing your risk of heart disease and stroke. You're also making your arteries to build plaque because your cholesterol, your bad cholesterol, within a few, you may have normal one, but eventually they will start going high, and that's a high risk. So we need to make those changes now. Limit sweets and red and processed meats. Eat fruits and veggies and whole grains, low-fat dairy product, poultry, fish, and nuts. Now, many people eat poultry, fish, and nuts, but they're eating the wrong way. You cannot have your poultry soaked in flour and you fry it. It's not good. You're basically eating bread with a poultry inside it. So just bake it or broil it. And then the nuts, peanuts is not a good healthy nut. Try to stay with almond nuts and walnuts. Those are a handful, and you don't want to eat a whole bucket of nuts and say nut is healthy. Everything is in moderation. So also include food that are rich in potassium. Potassium is really good for your heart, but you cannot take excess of it. Don't go and start taking potassium supplement without actually knowing what your potassium level is, just because somebody say take potassium. I've seen people do that and come back because too much potassium is actually, it can cause you to have heart attack. So don't just take something that somebody said take it. So such food, it's better to get it from your food. And food is your best source of getting vitamins and minerals. Taking pills and all that, some people take vitamin A to Z. It's not good. Get it from the fruit. So dried fruits, raisins, and apricots will give you potassium. And also, those are some of the things that will also increase your fiber intake, which increased fiber will also help you have a normal bowel movement. It will also decrease your cholesterol levels. So those are some of the things we can do. Eating beans and lentils, potatoes, well, not white potato, but not too much because potato is starchy. So whenever I see it, I just tell people to do it in moderation. And also you can see the serving size of all this food. Like a serving size of potato is like a quarter or half of a small potato. So you can't just eat 3 potatoes and say you're getting potassium. You're actually giving yourself diabetes eventually. Winter sport like acorn, spinach, broccoli, those are healthy. Beet, greens, avocado in moderation, and then banana. Banana is a very rich source of potassium, but it also high in calories. So I tell people to, if you watch your calorie intake, you can do a medium banana, but don't just eat a whole bunch of banana every day. It's too much. It's a lot of it. So now that I mentioned this, sometimes someone will say, okay, I'll just go ahead and eat ice. So that's what this slide is, some patients will say, so if I put it in my mouth, it tastes good, I should spit it out, basically. But moderation, whatever we eat is the recipe. How can I control blood pressure? Be physically active. Aim for at least 150 minutes of moderate intensity of physical activity per week. This is just to stay active. Now, to lose weight, they've increased this number to 300 minutes. So it means 1 hour a day, 5 times a week. That's how you get 300 minutes of activity. That's how you actually can keep your weight maintained. Limit alcohol to no more than 2 drinks for men and 1 drink for women. Take all medicines as prescribed to control your blood pressure and know that what your blood pressure should be and try to keep it at that level. Now, 10 ways to improve your heart health. You balance your calories, eating, weight, physical activity. It's not all, sometimes when I do obesity medicine, obesity doesn't really necessarily mean the person is eating too much or exercising less. There are still other things that are contributing to it. Sometimes it's genes, and there are some people that have other things that are impeding them, causing them to not be able to lose weight. So it's also good to have everything checked. Sometimes we believe, some of us may think we have thyroid issue, which is also a common reason for inability to lose weight. But it's not always the thyroid. So everybody will say, oh, check my thyroid. Yeah, it's good to check it, but it's not always the case, but it's always good. So increase your physical activity level and decrease your calorie intake. And it depends on how active you are. If you're a bodybuilder and all that, I'm not going to tell you to eat 1,200 or less calories. You're not going to be able to function. You're going to be sick and tired. So that's why you don't just copy whatever menu you see online. You have to have it tailored to you and your activity level. Reach for a variety of fruits and veggies. Try to stay away from sweet veggies like pineapples and all those sweets. And grape is very bad. It's my favorite fruit, but it's very bad for you. It causes you to gain weight because of that sugar. And then choose whole grains, but don't eat in excess. Check the serving size. Yeah, sometimes we might eat whole grain bread, but you're eating half of a bread. That's a lot. You just need 1 slice. Include healthy protein sources like from the plants and seafood. You can also eat Greek yogurt. Sometimes people will say, why do I eat in the morning? Greek yogurt, not the one that has all that sugar and everything. Greek yogurt. You can also do egg. You can boil egg, hard-boiled egg. You can eat the white. I don't like the yolk, but the white is where you have the protein anyway. So that gives you something to hold you up in the morning. You can get protein shake, the one you find the flavor that you like, and you can drink it if you can drink it normally. I don't. I only put it in coffee to drink. So when you use liquid non-topical plant oil, this is where they complain about our palm oil. We use palm oil to, sometimes that palm oil is because the oil things at room temperature, they consider it as bad oil, like coconut oil and palm oil. Those oil are not healthy. But if you're using palm oil, just use it in moderation. Don't use a lot. The other way to cut down on how much palm oil you use is to use red pepper. If you put red pepper in food, the color changes, and it's like you put oil. So then you use minimum amount of palm oil. And then choose minimally processed foods, stay away from frozen foods, sausages and bacons and all that. It's not healthy. And as we're doing all these things, subtract added sugar. So like water, drink water, eat an apple. Don't drink orange juice. I've seen some adults drinking orange juice. You're not supposed to drink orange juice and apple juice. That's not for you. And it's not even for anybody. And that's what I wanted to say in a few minutes. Stay away from all this. Drink water. You can drink tea. Try to sweeten it. Maybe honey if you really like sweets. Those kind of things, And cut down on salt and limit alcohol, and do all this wherever you eat. The thing is, sometimes we focus on only ourselves and we forget about our children. Obesity starts from childhood. That's when those adipose tissues are made. Once you're a baby, it starts building up. So, and it makes it easier. So when you're not eating, then it shrinks. And when you start eating, it just balloons up. It puts us at risk of having excess weight and obesity. The thing is, we should change our household to eat like we do. Some of us have made the mistake, we gave the children pizza and all that, buying frozen food and all that. But, whenever you wake up is your morning. So you can start making those changes, but you don't expect it to happen overnight. You can minimally, gradually introduce those healthy eating habits to your children so they don't have to go through what you just went through or what you're still going through. Also, it's good to add color to your food, make plate colorful. By adding tomatoes, those are some of the food that help. Tomato is good for your eye. That are orange colored and red colors are good for your eye. And things like berries and less of the bad food. Typically, fruits are free of trans fat and saturated fat, and they are low in sodium. But don't go and buy a bottle of orange juice and say you're supposed to drink orange. You cannot drink orange. One of orange juice is probably maybe 5 oranges. I don't know. I haven't checked it, but it's a lot of orange compared to if you're trying to eat an orange. You eat maybe 1 or 2. So that's why, and that juice is processed. It's added. There are so many things that are added to it. So finally, we're going to get to the common myths about high blood pressure. Some people say once in my family, therefore there's nothing I can do to prevent it. No, there's a lot you can do. Some of these things we have addressed. Some of the things you can do. Just because your family history has high blood pressure doesn't mean you have to have high blood pressure. I don't use table salt, so I'm in control of my sodium intake and my blood pressure. No, certain food have sodium in it, so you don't have to put sodium salt in your food. If you're eating some food, just especially canned food, they are really made with salt, and because the salt is one of the preservatives, so very high in salt content, and also chips and things. And the thing with the salt is once you get used to a certain level of salt content, that's what you will be eating. And also these are the myths, but I forgot to say, try not to be over. When you get your plate, you just start pouring salt on top of it without even tasting it. And for me, I don't even add salt. However it's good, I'll just eat it that way because it's not good. It's not a good habit. Some people may say they use kosher salt instead of regular table salt. They are low in sodium alternative. They are low sodium alternative, but they still have 40% of salt. So don't just go crazy on it. Someone would say, I feel fine. I don't have to worry about high blood pressure. Well, like me, it's a silent killer. So you don't necessarily have to have symptoms. You just have to monitor your blood pressure. People with high blood pressure have several symptoms of nausea, and sweats, and flushing. I don't have any of those symptoms, so I'm good. Like that is a silent killer. You don't really have to have any symptoms to show that you have high blood pressure. And then some people say, I read that wine is good for the heart, which means I can drink as much as I want. No, there is a limit. 2 for men, 1 for women. And a glass doesn't mean a tumbler. A glass of sunshine is 6 ounces. So 6 ounces. So, so that means 12 ounces for a man, 6 ounces for a woman. And you stay within that range. And then, so that is the final. These are my references: American Heart Association, Up to Date, AARP, and my images can go. I'll just place this one here. And also, I don't have any financial disclosure. I don't have anything to disclose. So thank you all for listening and going through all our technical problem. And then I'm ready to address any questions.
Okay, Ogechi, I think that questions, Ogechi, I think that you had a few in the Q&A. I think they were answered. I may have missed. Feel free.
Yeah, I see that the Q&A were mostly people that were reporting that the chat was disabled and they couldn't hear Dr.
Yes.
Mbah. but the chat, yeah, first of all, I want to say thank you to Lynda. This is just,
Yes.
you know, detailed information, very granular, very, very in-depth. And one request I would like to make to you, Dr. Lynda Mbah, is if we can get a copy of this PowerPoint presentation, because I would want to personally share it with my children, also share it on the ANWEP platforms, because this is what we need, this kind of information for our people that we're having. We can begin to encourage our boys and girls to go into the medical field, because we need men and women who look like us a lot in these areas. The first thing you said when you started this presentation is how when a Black person is suffering a stroke or, a heart attack, some people around may not even want to help. So, a lot of those things bother me a lot, and I just don't know what we can do as a community to help.
Well, sometimes, yeah, it's a good point that you brought up. The same thing you said was when I was in medical school, every single disease condition, they will say, highest in Black, highest in Black. I said, oh my God, am I doomed being Black? And then until we got to osteoporosis, we are the least. So because we have a higher bone density, so our bones don't break easily, it doesn't get weak easily. That's the only condition that they told us Black people are at advantage. So, and then wonder why.
Come on, how about cystic fibrosis?
Well, that one is there, but it's not a big condition. Many people don't even know. Yeah, you're right. Urgent. That's true. But that osteoporosis one, we are at an advantage being Black. Everything else we are at disadvantage. The cystic fibrosis is that genetic condition, but it's not. We don't have advantage over it. The only thing is that the socioeconomic situation and lack of access to healthcare, and also sometimes the fear of the medical community. That's like you mentioned, we have to have our children to be in the medical field. I have a lot of patients that will go and see their specialists. I'm the one that referred them to go to see this neurologist or hematologist or whoever. And they will go. And they will go there, and they will not follow what that doctor said. Unless they ask me, and I say yes. And I said, that's the specialist, that's their area of expertise. That's why I sent you there. So because they don't trust what that person is telling them, they want to confirm with me. I have several patients that have gone to the ER and they told them they need blood. And they said, no, they need to talk to Dr. Lynda. And the ER doctor will call until I speak to the patient and tell them, you need to get the blood transfused. They will not let them give them blood. So that is the lack of trust. And I think, so when patients don't have a doctor like that, patient that see, they will drive wherever. Even some of them, I told them I'm going to return Nigeria. They said they're going to follow me to Nigeria. So they will drive wherever I am to go see me. I have patients coming from Funny because they say, once you find a good doctor, you're not going to leave them. So that's the thing. We are disadvantaged in terms of the care that we get. Sometimes people don't take the time to listen to the Black person as a patient. So some of the times it makes our patient feel like they're not being heard, and they all just decide not to go see the doctor. And a lot of people have not seen a doctor as an adult, just whenever their mom took them to get vaccinated, and that's it. But thankfully, COVID, we say is bad, but in the African-American community, it actually was an exposure. It was an eye-opening thing. When the media, initially when COVID happened, they said It doesn't affect Black people. So a lot of Black people were walking around without masks thinking they are invincible. And then it changed that it really kills Black people, unfortunately. And then it started highlighting the risk factors, those things that I mentioned, having excess weight, being inactive, having blood pressure, having diabetes, having undiagnosed high blood pressure, actually. A lot of people, and then telling people when you're not in good health, you have a higher risk of dying from COVID. That really made a lot of African Americans seek medical care. That's what I saw. They called healthy looking young men and women in their 30s. They say, or 20, they say, I'm gonna check myself and make sure that I'm in good health. And that really opened it. Them are now getting medical care because they were scared of dying if they go contract COVID. So that preventative medicine, that's what I mean. You prevent it. This diabetes that is very common, a lot of people, I diagnose them as pre-diabetes because a lot of times some doctors don't do hemoglobin A1C. When you go and do your blood work and they're checking your fat work, it's gonna give you your sugar for the last 4 hours or the last 24 hours. And many people try to eat healthy and they are fasting for since midnight. So their sugar is usually normal. But I run hemoglobin A1C based on your risk factors. And when I do that, I'll see people pre-diabetes. Their sugar, their hemoglobin A1C is approaching diabetic level. Diabetes is 6.5% or more. Normal is less than 5.7. So some people are 5.8 or 5.9. And I tell them to change these lifestyle changes, changing the starch, most especially, because a lot of people don't really eat sugar. Changing the starch and increasing your activity, because when you increase your activity level, your muscle uses, the muscle will use the sugar when you're exercising. So exercise is one way to reduce your blood sugar level. And those people, and I always tell my patient, if you don't change anything in 3 months, because we check it every 3 months, if we check it again, it's gonna go high. Some people go from pre-diabetes to diabetes. The only people that change it around are patients that say, I have family history of diabetes. I saw what my grandmother did. I don't want to be on insulin. I don't want my kidney failure. I don't want anybody to chop my legs off. And they change it. And they say, give me 3 months. I'll check it again. Those people usually return to normal. But the ones that don't make any changes, it's going on. And eventually becomes diabetes. And those are people that will have undiagnosed diabetes without even knowing it, that they're walking around. And diabetes puts us, I didn't handle diabetes today, but diabetes is actually equivalent of heart disease. Really, it hastens that plaque formation, that plaque buildup on the arteries. When you have diabetes, is faster. It's a faster process. So that's why we need to work hard on the sugar and starch and increasing the activity level. So for now, we will just have to deal with ethnicity, racial ethnicity. But some of the things is that the medical community have not researched well on things that affect Black people. And Black people are hesitant to enroll in studies. Most of the medicine we're taking, a lot of Black people did not participate in the study. So we don't know how it affects Black people until it's actually on the market. Because a lot of us are hesitant about enrolling due to that Tuskegee trial. So people are still fearful of being an experiment. So one of the things that we need to work on is to participate in studies. Now, recently, it was just changed. African Americans were having chronic kidney disease and end up with dialysis more than any other ethnic group. But why? Because the creatinine, the EGFR, which tells us the kidney function of somebody, they had a different one for African Americans, which is a higher threshold. So if a non-African American has a creatinine of 1.2, it might put them and say that their kidney function is about maybe 65%. But an African American, it will say it's about 70 or 80%. And then when the creatinine level goes up, and so these African Americans will not be taken care of because technically their kidney is still functioning okay. So then they suffer from this prolonged kidney disease that eventually becomes kidney failure, and then they end up on dialysis. So they just changed that creatinine calculation just during the pandemic. to now use the same for everybody because they were finding that disproportionately African Americans were being left untreated for progressing kidney disease because they were given a higher threshold for kidney failure. So some of those things are some of the things that we are facing in some way or the other. And I know that some of our socioeconomic studies, are affecting us. So the more Americans we have in the medical community and people that will listen, not just African American, you have to be able to listen to your patient and see things from their point of view. That way, it will encourage them to see more doctors and attend and prevent things sooner than later.
So let me add to that. So you are right. It's a lot of things involved in terms of healthcare in general and what has happened in healthcare over the years.
Oh,
It's been over.
wait, Dr. Aji. So everyone, this is Dr. Miriam Aji. She's a general surgeon practicing in Dallas. That's who is speaking. All right.
Thank you. But also as a specialist, what I also see is that we don't go to the doctor. You need to go and see your primary care like Dr. Lynda before you're sick. What happens even in our community, not just in Nigerian community, but also in just African-American community, and also Hispanics, is that they don't go to the doctor until they're sick. What lies with that is that, for example, that creatinine you're talking about would never be measured, right? Until you're sick. And you and I, both from what you've just said, you're not going to have, when you start having the symptoms of diabetes and high blood pressure, it's already bad. Otherwise, it's a silent killer, meaning you don't have symptoms until it's late. So, and the way to take care of this ahead of time is to see a doctor regularly. In general, kids, when you're born, you have pediatrician that you follow. Most pediatricians will kick them out at 18. Then you need to have a primary care physician like Dr. Lynda and so many more. And then see a doctor at least regularly once a year. When you're young and 18 to a certain age, and then 40 and above, you may need to see more than, more regular. Otherwise, how are you going to know these things until it's too late? You're busy eating all this starch, fufu rice, thinking you're healthy, and you're not, until one day you end up in the ER. And even sometimes when patients I just had a patient end up in the ER in June. She just came back this weekend. But in June, while she was in the ER, her A1C was elevated. She was treated with insulin while she was in the hospital, told to follow up with her PCP, and then prescribed those things that she needs to follow up on. So from June to coming back now in February, it wasn't being treated because she didn't follow up with her PCP. She didn't mention the fact that, oh, by the way, they were treating me with insulin when I was in the hospital. Nobody would treat you with insulin if something's not wrong. They just don't give it to you because, we just feel like you look like you need insulin. But these are the factors that affect minorities in general. So you're right. There is a global thing involved with healthcare at the top. But while that is being fixed, we need to have individual responsibility as well. Meaning we personally have to take responsibility for our health. Meaning also part of the reason why people, you say bystanders are more likely not to help somebody who's having a stroke or heart attack. Again, most people that are having a stroke or heart attack are having it at home, not by the roadside. So the people that are actually not helping them are families and friends. Why? Because they don't recognize it. Because they don't listen to this type of talks to actually see and hear and know when to call for help. Most of the time as Black people, you don't feel good, you go lay down, take a ginger ale. Or, well, this, take a ginger ale, it'll be fine. So you don't feel good. Yeah, well, that too. Rub some Vicks on your chest and then somebody goes to sleep and they don't wake up the next morning. So many things not to, because again, it starts at home. You are right in terms of there is disparity, just like disparity in every facet of life. There is also disparity. It doesn't come to healthcare and then stop, right? If there's racism in all levels of the world, it doesn't come to healthcare and then stop, right? Because those same people that you see either in the streets or at your churches or wherever that you may experience racism from are also doctors, nurses, healthcare professionals sometimes. So yes, it is there, but it is our duty. it is now very clear, especially since we now know this. I used to say, nope, when I go to the hospital, I don't want anybody knowing that I'm a healthcare professional, right? My mom used to go to the doctor. Well, my daughter is this. I used to say, no, ma, just let them take care of you. You don't have to. But now, in the past 2 years, that has changed. I want you to know that that person has an advocate. So when you go to your doctor, it's okay to let them know that, yeah, Dr. Lynda is my sister. It's okay because, one, that's an advocate for you. That person, if they're not dotting all their I's and crossing all their T's, they need to know that. They need to dot all their I's and cross their T's on your behalf. So it's important for you to go. And I learned this from a friend, an Indian patient, okay? An elderly Indian woman that has 2 doctors. She used to be a doctor, by the way. Didn't tell me that, but her son is a surgeon, but out of state. And I was about to take care of her. And her daughter is a family practice, also out of state. She made calls to both of them and made sure she told me. Again, because my standard of care is my standard of care, regardless of who I'm taking care of, it's not bothersome. But down the road, in one of the group that we both belong to, Lynda, this lady talked about why it's important to do so. Because sometimes people, women especially, may not be listened to by their doctor. When a woman is having a heart attack, she's more likely not to be listened to. When a Black woman is having a heart attack, she is even much more likely not to be listened to. One, because, so that happens. So it's important for you to remember to advocate for yourself. That's one. And 2, go and see your doctor. Don't wait until things are broken. The same maintenance that we do on cars, we don't wait for them to be broken before we go get them fixed. We get oil change, we get those things. Well, those cars are not much more important than your body, because without you, you don't get to drive the car, right? Or just park in the garage. That is the part that we keep forgetting, that's what we need to do. And so when I talk about personal responsibility, I hear this all the time. Well, my last doctor didn't take care of me, didn't listen to me. Well, then get another one. None of us are going to go to the store, and buy a big screen TV, come home, put it up and plug it in, and it doesn't work. And we just keep looking at it. No, we take that sucker back, don't we? But when it comes to our health, you give you medication, you're taking blood pressure medication, but you don't even check your blood pressure to see if it's working. How do you know it's working? You're on diabetic medication, but you don't check your sugar. How do you know it's working? How do you know that medication is good for you? Like Dr. Lynda said, many of the studies that are done with people that are available and signing up for those studies. Yes. And of all of us here, I can maybe say that, I don't know how many people are on this forum, but I can possibly say that maybe 1 or 2 of them have ever been in a study. Otherwise, most of us are not in studies. That's why when we need a bone marrow transplant, we can't get one because there's no match, because guess what? People don't even try. Okay, so these are the things that needs to be discussed in our communities, needs to be said over and over again, and personal responsibility. So to me, it starts with primary care and going to see your primary care doctor, because your primary care is going to put you in the right direction of where to go. It's not magic, or else you're your own doctor. Even if you're your own doctor, you still need a doctor, So anyway, Lynda, this is an awesome presentation and you did very good. Proud of you.
Thank you for adding what you added.
So much. Thank you so very, very much. This community conversation has spilled over, but this is great information, and it's not every day that we have the opportunity of bringing in intellectual powerhouses together under one roof. So, I don't mind. If anybody else has a question, let's go for it. I want to thank Dr. Oji that just made a very valuable contribution. Hopefully people are listening. People who weren't able to join the call today are listening on Facebook or YouTube channels. One of the good things that came out of this COVID-19 pandemic is the fact that Black people are very much aware now of where we stand when it comes to pre-existing conditions, things that make us more vulnerable to suffering severe symptoms from COVID. And with that came about this outreach and education, which I feel like we ought to continue even after COVID is over and done with, which I don't know if that's going to be the case. I think it's probably just going to be like another flu that we have to deal with. But I think we ought to have this kind of safe spaces where, you know, we can bring together professionals, doctors, to educate us. Because let me tell you all, it's very difficult to get our people to, like she was saying, buy into preventive care as opposed to, you know, landing in the emergency room when it's become a crisis. I have boys, I have sons, I have brothers, men, you know, think that, I don't know what it is with men. Some of them don't feel like they have to prioritize their health until they get in their 50s or 60s. Oh, I'm fine. Oh, you don't have to do this. No, don't bother, I'm okay. We had a health fair that we partnered with the Dallas County a few months back. And a man came to that health fair. We checked his blood pressure. We had to check it like 4 times. It was in the 200s. And we were like, okay, maybe this is not working properly. Let's try it on this arm. Let's do it. And that was why I asked Dr. Lynda, when we're checking blood pressure at home, should we do the left or the right? And hopefully we'll still have time for her to answer some of those questions. But he said, oh, I'm fine. I get up, I'm fine. You guys are making me nervous now and stressed and all that. You know, he didn't think that it was a big deal just because he's able to get out of the bed and go. So this is a problem. It's a problem. It's a conversation that we ought to keep having, even in person, outside of a virtual environment too. So in my head, I'm already thinking about having a community conversation in person with a panel discussion with doctors like Lynda and Miriam Oji. And if there are any other doctors here, Lynda, you know I'm gonna keep bugging you, and I'm going to have you bring other doctors in to help us in this regard, because we need to keep creating awareness. We need to keep letting our people know how important it is to prioritize our health. You know, men, women. And like Dr. Oji said, some of us women, when you go to the doctor, they don't believe us when we say that we're having certain symptoms, you know. So we need people who look like us. We need more representation of men and women who look like us in this in the medical field. Go ahead, Israel. I'm sorry.
No, I'm sorry. You know, first of all, thank you, Gochi, for Okechi, for the platform, and I want to thank Dr. Lynda and Dr. Oji. The information you shared was quite insightful. Thank you for all of your experiences, and most importantly, the fact that you care is what I can hear from your voice. And we know that people don't care about what you know until they know that you care. So as I was, taking down some notes, some things that occurred to me, this could be a messaging issue, a marketing issue, because I'm a marketing professional as well. I started to think outside the box, say, how can we something that men respect or men value or can help push the message is to have activities or to have events or to have opportunities for the church to help doctors like yourself to echo the message about, making sure you're visiting your PCP. I mean, I myself, that's something I should do. I can't remember I can't remember the last time I went to go see a PCP, and I'm a former professional NFL player. I'm always exercising. I'm always, feeling good about, what I do physically to take care of myself. But that is something as you were, talking. I was like, what are some of the other ways to have a conversation within an environment that people already respect and people go to every Sunday? So that's why, also being a man of God, who is an ordained, pastor, that's what came to me as well, is how can we extend that towards the church and have conversation with pastors to start echoing the same message that you're saying, because within the silos that we're in right now, one of the easiest places to help, carry that out is through the churches. In addition to that, I was even thinking about also some of our, people who are also, either football players or people who are in the entertainment industry, just, because that's how I see it, as a marketing issue, as a messaging issue. Because the more we normalize the conversation of men visiting, their private care physicians, being able to talk about places that they feel vulnerable, that could be another way, for us to have a conversation that involves everyone and doesn't isolate them. Because I know, as a man, pride is an issue, fear is an issue, but I do believe that is something that we can really amplify in other arenas, besides what you're doing now, which is great because I'm a part of it. I'm just thinking outside the box if there are other angles that we can approach to tell that story.
Thank you so much, Israel. That is a great input. And we have discussed that at a previous community conversation. I believe it was Dr. Hackney and Bishop Riley from Texarkana that were discussing about a framework in the church to help address health issues. So they were thinking about starting a health, I believe they called it a health ministry within the church, whereby we can bring in professionals to be part of that committee. So
Yes.
Healthcare professionals like doctors to be a part of that committee. And that's something that you can also do, in your church. Earlier today, this Sunday, I visited a church in Garland, and I talked to them about what this project we're working on, and also about this community conversation. So if you want me to come and talk to people to get the conversation going, that's fine. If you want to put together a committee, and you can reach out to me for doctors like Lynda to be a part of it, we can work together, we can collaborate, because that's the beauty of this work that we're doing, is making those critical connections and being able to keep this conversation going and extend it as much as we can to those places and areas where we can reach our target population. Sandra Abusomwan has her hand up. Sandra, can you unmute yourself and ask your question?
Yes,
so
ma'am.
Israel, let's talk after this event.
Okay,
Yeah.
Thank you.
Sure.
Thank you so much for taking my question. Thank you, Dr. Lynda, and the other doctor. Sorry, I forgot your name. Thank you all so much for this. It's really, really informative, and I'm really appreciative of what you all are doing. Okay, I understand everything that was said, and I really appreciate what you said. But I'm a nurse practitioner, and I take care of patients as well. But I am running into issues with some of these patients that are really, when I say stubborn, they are stubborn. You literally explain to them, this is what is going on with you. If you don't take care of yourself, you're going to literally die. And yet they don't do anything with them. I have a particular patient I'm having issues with right now. He is like almost 400 pounds. Okay. The last time I saw him, I had to send him to the hospital. I do house calls, so I see them at home. He was starting in the 70s. His blood pressure was in the 200s. He spent, I don't know how long in the hospital. And then when I did a follow-up, he was okay. He was with his sister. Then this last month in January, when I saw him again, his blood pressure is back up again in the 180s. And I'm asking him, why are you not taking your medications? Oh, I took it this morning. I said, okay, give me your pill bottles, your pill, the little pill, whatever. This guy had not taken his medication for 3 days. So what do you do with those kind of patients? How do you, I have literally told him, I'm gonna come here one day and they're gonna tell me you had a stroke. What are you gonna do about that? I have cut out just being like sugar. I don't even know how to sugarcoat anything anyway. I told him straight to his face, this is what's going to happen to you if you don't take care of yourself. But he still doesn't listen. What do you do in that kind of situation?
Oh, well, thank you. That's my neighbor. So, thanks for joining. The thing is, for me personally, my patients, it's not like I didn't select them, but I let them know when I diagnose something. Like, you can see myself, I have excess weight. I put myself in their situation. When I'm telling patients, you gotta lose weight, I tell them, I understand how hard it is, and they know that I actually understand how hard it is to lose weight. Now, when a patient has high blood pressure and they see me, because I had a similar patient like yours, like the guy you described, but I don't see them at home, but he will come. His blood pressure is always 190 over, whatever, 190 over, 110, 190 over. And then he won't take his medicine. He's asking me, when do I come off the medicine? I said, you're not even controlled. I don't want you coming here, wasting your time and your money and wasting my time, because I'm not a quack doctor. So if you're not going to listen to what I'm recommending, I'm only your consultant. I'm going to make my recommendation. If you want to take it, you take it. If you don't want, you don't take it. But I don't want you wasting your time and my time coming here every day to see me. And I'm having to, because he ended up having, what is it called? Disease. Because when you have uncontrolled blood pressure, it progresses. Your kidneys start failing. You start having protein in the urine. And like Dr. Miriam pointed out, when you don't do your preventative care, you will not see those minute changes that are happening, because you will be walking around thinking everything is fine. That's why your insurance covers your preventative, unless you get one of these weird insurance that only cover catastrophic things. They don't get those kind of insurance because they're not caring for your well-being. You need to get insurance that covers wellness. Once a year, they pay for your preventative care. And you get, for me, I screened for kidney disease and everything. And this guy ended up, I need to refer him to the nephrologist. I told him, I don't want to be seeing you anymore. You're not listening to what I'm saying. So the doctor-patient relationship is not working out well. So I basically fired them without really firing them. But once I had that talk, they either change or they find another doctor, because I tell them it's a waste of my time to be sitting here and telling you stuff, and you keep coming back with this high blood pressure. He will go to the hospital. He had a stroke symptom. He will have heart attack symptom, those kind of things. So, I mean, what do you want to leave? You want to end up with, well, some people, when I tell them all the things that will happen, you leave your blood pressure on control, you're going to end up with congestive heart failure. You're going to end up with stroke. You're going to end up with kidney failure, and you'll be on dialysis. And especially if you do not control the ones with high sugar. When I tell them, the men, I learned that in residency, when you tell them that they're going to have erectile dysfunction from their uncontrolled diabetes, they said, what? They change. Some of them, if you tell them they're going to have amputation, some of them, it doesn't scare them, but the erectile dysfunction scares them a lot. So those things, I lay it out and say, this is the progression of what you have. If you don't make changes, this is what's going to happen. And that's how it happens. And they say, how come nobody told me? I say, well, I'm telling you now. So it makes them change. It makes them turn around. Now, someone like yours, there might be other issues that are happening. Maybe sometimes the medicine will cause them to have side effects. And so that's what I see in some patients. They may not take the medicine every day, because when they take it, they feel dizzy, they feel lightheaded.
What is the real reason why you haven't taken it? Does it affect you? Do you have trouble remembering to take the medication? Just going through that with the patient. And sometimes you will find that there are other reasons. And then there is also a handful of people where there's just no reason. They're just knuckleheads. They just don't care. Or at least they think they don't care until they get really, really sick and dying. And then all of a sudden, they want you to do everything to save them. And then you tell them that at that point, there's really not a whole lot you can do. And this type of story sometimes resonate with some people and is able to kind of push them in the right direction, but not all. And again, I'm reminded that in training, you're not gonna save everybody. You're gonna save some. We should definitely try as much as we can but you're not going to save everybody. And so what Dr. Lynda said is important. Sometimes you may just have to fire a patient to get them straight, because by the time they get fired by a couple of doctors, they start to go, well, it's not the doctor, it's me. I need to do something differently. Because what also happens is that when we keep seeing them and they're not doing anything, and we keep seeing them, they actually think that just going to see a doctor is all they need, that they don't need to do what the doctor says. And so that's another way for them to actually believe that they're doing all they need to do, because after all, they're seeing a healthcare professional. But if you're seeing a healthcare professional, but you're not doing jack of what they told you, then you're better off not seeing them. That way, you know that you're really, really just not doing anything. And I think in that aspect, that's all you can do. But don't hesitate to fire a patient. But before you do so, make sure you document series of times where he's just being non-compliant and just refusing care and all that stuff.
Thank you so much.
It's a good point, Dr. Oji. So if somebody, a patient is refusing treatment or refusing the treatment plan or the medication, is it now, do we now factor in mental health issues and try to evaluate them for that rather than just dismiss them?
Definitely, always. The truth
Yeah.
is that most people, there's what we call, at least from my side of what I do, I always need informed consent, right? And the thing about informed consent is kind of like what Dr. Lynda is saying, being I'm just a consultant. Our job is to, I think a lot of times people forget that the doctor's job is not to make the decision for you. The doctor's job is not just to treat you, right? The doctor's job is to give you all the information you need to be able to make a reasonable decision. And what's a reasonable decision? A reasonable decision is that if there's fire on the stove and somebody says that water is very hot, be careful. Well, reasonable decision would be that when you go to pick up that water, you're going to use some kind of insulation. You're going to be careful. You're not going to pick up that water and run with it or jump up and down with it. That's a reasonable decision. So if somebody hears that and decides to take the water and jump up and down, one, did they hear you? Two, are they well? Those are the things to consider. So if they're well and they didn't hear you, then maybe they're just being risky. Maybe they're just really being a risky person. And so sometimes even in medicine, we have a hard time deciphering which one is which. That's where we get the ethics committee and the psych people involved and stuff like that. But in terms of what we're discussing today, in terms of this example that this young lady just gave, and this patient, you always have to, factor in mental health, because they could be depressed. And when you're depressed, telling me I'm going to die, telling me, this will happen, they don't care sometimes in a severe depression. They really want to die anyway. So what you're saying, it sounds like a good idea not to take my medication, So we really need to factor that. And contrary to what our people tend to think, mental health is across the board. Mental health is privilege in Nigeria. It's prevalent in Nigeria. It's also prevalent here. And there are reasons for people to have mental health. It's not, it's not the taboo that people tend to think it is. We go through so much stress in life. That alone can cause you to, just have anxiety, have depression every now and then. You can go through, a death in the family, you can lose a job, even healthcare itself. When you're 400 pounds, it's not easy to lose the weight. You don't get up and just start working out. It's very difficult to move a 400-pound person. It's not the same as moving a 120-pound person on a treadmill, boom, boom, boom. No. So those people are, even when they try and they don't see any result, they can go into depression.
That's true.
Yeah, this particular patient, though, he is just stubborn. He just doesn't do anything, take care of himself, period. That's just, we're just down to that point right now. He just doesn't care.
You got to make the decision.
So
that's hard. That's really hard. Chioma Olunkwa has her hands up. Chioma, can you unmute yourself and ask your question?
Okay, hi, this is Chioma Olunkwa. I'm a nurse practitioner with Methodist. So I just want to chip in one thing. I appreciate everybody. I like Dr. Mbah PowerPoint. It's just superb. It's very outstanding anyway. you kind of take me back to my pathophysiology. That's very, very interesting. So I have this patient. I just wondering why you can see heart failure among the young adults now, like 20, it's common now, 20, 22, 25, from 20 to 40 years or below that. You start wondering, why is heart failure among the young ones? I thought it used to be adult stuff, heart attack. So we now begin to know it's caused by drug, polysubstance abuse, like taking cocaine, marijuana, meth, all those drug issues. And like I have one, this case, it just happened 2 days ago. This guy came that was on, we discharged him on January 14th. So he has a PE, EF is 20-25%. He's been battling with heart failure, developed sadly PE, DVT. So we started this guy on Comodine and unfunded and told him to follow Parkline if he can get ICD, but he didn't go. So he came back 2 days ago. That was early in the morning, like 6 a.m. in the morning. The doctors are capped for admission. So they now left him for the morning people coming. So on reaching to the hospital, they told me, hey, Choma, you have admission, we're gonna do and so. So I arrived there 7 a.m. I looked at the time the guy came 6. When I went there to ask him H&P, he was like, I can't, I'm not feeling good. I'm having shortness of breath. I don't know if I can make it. I was like, when did it start? He said, he just started like this morning. He was sleeping at a point he cannot breathe. The girlfriend now brought him, called the ambulance, they brought him to the hospital. So he said all his body is aching him. He's having chest pain. I said, can you describe the chest pain? He just said, he just come and go. He just described it. So I was like wondering, did the blood travel? I'm trying to do my workup by other CTA and other labs just to find out what's going on. I called pharmacy, let's give her Lovinus treatment based on the weight. On the process, before how many minutes, he hasn't even no workup. They started unresponsive. We call code, the boy did not make it. What am I trying to say to the 8-year-old just passed like that, EF of 20-25%, DVT, PE, thrombus in the main artery, you know? So because of drugs, and he's morbid obese too, which is a risk factor too. So what am I trying to say? This kid doesn't listen. There's so many things going on. They don't care about their life because at that age, they don't really understand what we're talking about. So I think we need to educate them more, even our kids, even our relatives. You know, it's not only hypertension, or they will say cigarette, only cigarette. All these things has impact in the heart. So they have to be very, very careful on the friends they associate with. Because all these diseases we're finding among the young kids now, not even the old ones that used to eat. You know, so that's what I want to chip in. So this is very, very interesting. I appreciate this kind of like take me back from where I'm coming from so many years. Thank you so much, everybody.
Thank you so much, Chioma Olunkwa. That is a very, very great, solid input. And it's going to be a conversation, a topic all by itself. You know, Dr. Lynda's presentation covered smoking. It didn't quite go into drug abuse and all of that, because to me, that's like a little too extreme. And we, you know, sometimes we tend to be kind of in denial of the big issues like drug use, but it's becoming very, very, how will I put it, a community conversation. And hopefully we can get our children to register and listen firsthand from our healthcare professionals, how this can impact, you know, young adults in that age bracket. So that is a very great input. And unless any of the doctors want to say something, I feel like this is a problem, is a big problem now that, you know, we ought to be addressing as a community. All right, Miss Lynda, do you have any other questions in the chat?
I am checking. Well, let's do this. If there are any questions, go ahead on and raise your hand or unmute yourself and then ask your question. I don't see any.
Okay.
I think someone asked me.
Yeah, I think Dr. Lynda already answered my question on the which arm. So thank you, Dr. Lynda. I see that response.
Yeah, so let me also other people can hear. It's the left arm. It's closest.
All right, so the other question I had is, I know that you talked about foods that we can, the lifestyle changes, which includes dietary changes that can help us minimize these conditions such as diabetes and high blood pressure. And it's very difficult to have to plan a great diet and maintain, the required amount of vitamins from vegetables and other food sources, because we're busy, we work, we do other kinds of things. And I was wondering, because you mentioned that we shouldn't focus too much on supplements. Should we avoid supplements completely and then focus on getting all our vitamins from food sources?
Well, not really. So I recommend multivitamin, just one multivitamin, not vitamin A, B, C, D. I have so many patients taking like lots of, they will take supplements. A lot of Americans will rather take all the supplements in the world, and they will not take prescribed medication. So, and the thing is, all these supplements, whenever I can make supplement in my kitchen, as long as I call it supplement, FDA does not regulate it. And many people don't know that. So many of those things you're taking, you don't even know how pure they are, and you're taking them. So multivitamin, one of the women's there. And then if you have osteoporosis or osteopenia, which is weakening of your bone, then you can take extra calcium and vitamin D. But anything else, you don't have to. If you check your blood and your vitamin D is low and your multivitamin wasn't enough, then you can take extra vitamin D or B12. But many people just start taking these vitamins. We can, to answer your question, our food has those minerals and vitamins. You just have to find those food. They call them super foods. And so that means you don't have to eat a lot of it to get your vitamins and minerals. Things like broccoli and spinach, those are super food. They are packed with minerals and vitamins. Of course, we may not get everything that we need. So that's why you can take those supplements if you need to. But otherwise, find those super food and eat them. You will get most of the things that you need in your diet than taking supplements. And supplements, when you read, also see they have.
All right, thank you, Dr. Lynda. I think we should call it a day. This conversation is so good. I mean, I can go all night and I won't get tired, because this excites me a lot. Health concerns, health issues. But I think we've, let's just give Lynda some time back to recoup. She's invested a lot in this community conversation, and we don't want to be ungrateful and keep going on and on and on and, asking too many questions. But thank you so much, everyone. I'm going to personally reach out to everyone in this chat today. I want to make sure that we get this conversation going. I'm going to be inviting Dr. Orji for a future community conversation. And I'm also hoping I can get some of the nurse practitioners involved for an in-person panel discussion, community conversation. So thank you so much, everyone. And hope we can connect soon. Thank you, Dr. Lynda. It's a great pleasure and honor to have you. We see every day, we're friends, but sometimes we don't discuss things like this, So I'm very, very grateful that you were able to put some time into developing this PowerPoint presentation and on this particular topic. Thank you so much. And if you don't mind sharing with me, emailing me a copy, I would really, really appreciate that. Lynda, you want to close?
You're
I
welcome.
just-
Thank you so much.
Oh, no, I just want to recognize Dr. Israel. Right. Here, yeah. Are you still there, Dr. Israel? All right, but he says, thanks, everyone.
All right. Thank you, everyone. Good night.
Good night.
And have a blessed week.
Good night. Thank you.
Night.
Thank you,
Bye-bye.
everyone. Thank you.
Bye-bye.
Thank you.